Amazing. Thank you, Adrian. Thank you, Rupa. Thank you to the Dutch test. Now, today we're going to take about 45-ish minutes. We may go a little long depending on the Q&A. I'm going to go first, and I'm going to do an outline of the Dutch test from a perimenopause, menopause view. And then I'm going to hand the slides over to Dr. Rice, who is going to talk to us about hormone replacement therapy. So the reason that we're doing this live class today is I'm getting ready to share my screen is to give you a little intro, especially if you are new to the Dutch test, if you are new to perimenopause and menopause, you're not entirely sure how to look at the dials of the Dutch test. Now, do please keep in mind, we only have about 45 minutes. So this isn't going to be the most all-encompassing live class you've ever been to. However, it is the teaser to the boot camp that we do have coming up in March that both Dr. Rice and I will be a part of. So first and foremost, the reason that we want to talk so much about perimenopause and menopause is because both Dr. Rice and I and a countless number of other women feel that is very misunderstood. And for decades, the transition to perimenopause and menopause has been approached, let's just say, like less than logically. It's a little bit more like, this is natural, this is what happens, this is, good luck. Here's the birth control pill, here's an antidepressant, or there's nothing that we can do. And because of the massive shift in hormones that we have in our body, predominantly that drop in estradiol and that drop in progesterone, and of course, the change in androgens for most females, it's the drop in the androgens, it impacts so much. So what are the statistics? Why is this such an important topic to you as a practitioner? All women go through menopause. Women spend a third to a half of their life in menopause, which is a lot. The average age of menopause is about 51 years old. And if you live another till 80, 90, 100 plus, you're going to spend a long time without those hormones. And it's really important that you are protected and understand what's going on. In the US, 2 million women enter menopause yearly. It's about 6,000 women per day. And don't judge me. However, ChatGPT is taking over the world. So I asked ChatGPT, hey, ChatGPT, let's talk to me about the future of menopause. And ChatGPT said by 2030, we are in 2024, so in 6 more years, the world population of menopausal and postmenopausal women is projected to increase to 1.2 billion, with 47 million new entrants each year. So I've said this multiple times. If you are new into understanding perimenopause and menopause, you're going to become quite the expert really quickly, because a lot of your clientele are probably going to be in that age. Especially if you are late millennial or Gen X, you are already there. And those mid to early millennials are right on their heels. Let's get a little terminology and then we'll move into more of the didactic stuff. Perimenopause, it's the 6 to 10 year transition before you become menopausal, which I'll explain in a minute. And this can create several system-wide symptoms. And the system-wide is where I really want to emphasize, because a lot of people feel that the symptoms are just hot flashes and night sweats, maybe some sleep disturbances, some cycle changes, and that's about it. And that's actually not true. In fact, formally recognized, are about 30 plus symptoms, 30 to 40 symptoms. However, we're now adding to that symptomatology every day. And I'm going to show you a survey of just over 3,000 women that was done and the top symptoms they reported in perimenopause and menopause. Menopause is the day that she's had no period for 12 consecutive months at an appropriate age. The reason I say an appropriate age is if you have an 18-year-old who has gone 12 months with no period, that's amenorrhea, and we have to figure out why. That is not menopause. But if she is at an appropriate age and has gone 12 consecutive months, congratulations, throw her a party. I don't understand why we don't get tiaras and banners and celebrations. We enter menopause. I'm going to change that. But the average age is 51 years old. However, it can happen sooner and it can happen later. And just because she has gone 12 months with no period doesn't mean she's symptom-free anymore. Now, I also want to point out that signs and symptoms may not be that noticeable. They're probably not coming to you saying, I have bone loss, unless they know they have bone loss. They're not coming to you saying, I think I have cardiovascular symptoms. Most people don't really feel when their carotid arteries have problems or their blood pressure is high. Eventually, they may feel it, but in the early stages, they don't. What they're coming to you with are the symptoms like fatigue and hot flashes, vaginal dryness, and the mood changes, etc. Postmenopause is from month 13 of no period for the rest of her life. And of course, in there, she may still have symptoms as well. And then we can't forget about surgical menopause. Surgical is when she's had her ovaries removed and it's immediate menopause at any age. If she has had ovary removal at 28 years old, then she has become surgically menopause at 28 years old. And obviously, with the removal of the ovaries, this can also cause system-wide symptoms. So what do I mean by system-wide symptoms? So there are roughly, depending who you ask, there are 10, 11, or 12 systems in the body because sometimes they lump together like genital urinary or musculoskeletal. They'll link those together, but if you separate them out, we're at 12. So here are the 12 we've got going on, right? Cardiovascular, digestive, endocrine, immune, et cetera, through the body. Going through menopause, this menopausal transition, unfortunately, negatively impacts all of them. And this is why it's so important you understand what's going on with the decline in hormones, that it's not just about hot flashes and night sweats. Although from a, let's say, more natural approach, there are definitely herbs and vitamins and things that can help reduce or eliminate hot flashes and night sweats. But you don't want to miss the big things. We don't want to miss the heart health and the metabolic health and immune health and the bone health, et cetera, that may not be touched by some of these herbs, or at least you may need to understand how heavy you have to hit it. So I joke about this often. I don't know who designed perimenopause and menopause. 10 out of 10 would not recommend. And I would like a word with them. And I say this a lot. I don't necessarily need to be the goddess of the world. That seems like a daunting big job, but I would like to be the goddess of the female body. I would like to make some changes, some upgrades. If my iPhone can get an iOS update all the time, even when I don't want it to, I would like to update some of our systems that we have in place to keep up with the world. Now, there are some pros, though, going through perimenopause and menopause. And this is definitely, I don't ever want women to think it's a doom and gloom. And hopefully when you're educating about perimenopause, it's not doom and gloom. I need you to understand the what's happening. We're going to, in the boot camp, we will be talking about the research around all of these big systems and what's happening and related to the Dutch test. But you can be very proactive about it. You just have to know about it so we can be proactive about it. But some of the big pros, though, are that a lot of women, as they come through, they find that they have stronger boundaries. Don't mess with somebody who's in her 40s and 50s and above. Just don't mess with her. She has less of a mouth filter, so maybe she's coming more into her authentic era. Maybe she has not lived the life that she has wanted or been outspoken about the things she wanted to be outspoken about. And that decline in hormone does change some of those neurotransmitters, and she really doesn't care anymore. It also helps in this transition. She's figuring out who she is because she's going to live the next several decades in this state with your support, of course, helping her be proactive. So who is she? What is she going to do? What is she going to accomplish? What will she put up with? And the final thing that I love is that going through this transition can be a real wake-up call for a lot of women and help them really examine their health, because what they were doing wasn't working, or was working when they're younger, but it's not quite working now. And they need your guidance to help get them to that next level, or to realize, hey, I used to be able to multitask like crazy and now I can't anymore. I'm the short-term memory blips are affecting me. Or, hey, I used to be able to run or lift heavy and now I'm noticing the muscle pain and the joint pain is really getting me. What does that mean? And you will be there to help educate her. So what's actually happening hormonally, what's going to show up on the Dutch test? It's an unconscious uncoupling. So there's this one research article that says that systems in our brain in puberty couple, they come on, and then in perimenopause, they start to uncouple. They start to pull back. And so unconscious uncoupling, the reason it's unconscious is she doesn't want it. And she's getting a lot of these side effects in the process. So what's happening hormonally? When she goes through childhood and then into puberty, we have, hopefully, cross fingers, a regimented look at the hormones. So if she has normal expected cycles, she has a rise and fall and estrogens and progesterones throughout her reproductive years. And then because of that uncoupling, we start to get into the chaos. So progesterone, which is the solid line, estrogen is the dotted line. Progesterone starts to fall first. She's not ovulating like she used to. Her ability to produce progesterone isn't as great as it used to be. Estrogen gets wild and crazy and then gradually declines as well. So do you need a Dutch test in perimenopause and menopause? Of course not. You don't. You don't need testing, especially when Dr. Rice talks about the hormone replacement part of it, but it's wildly helpful. There's no law guideline that says to determine somebody's menopausal, you have to have a test. To determine somebody's menopausal, it's 12 months with no period. But the actual numbers information you're going to get on the Dutch test, coupled with other laboratory markers you're going to run on them, cardiometabolic, thyroid, maybe some nutrients, etc., are going to be really helpful in the ability to be proactive and navigate this so that they thrive. So when it comes to collection on the Dutch test, this is something I get asked a lot, and Dr. Rice does as well. How do I know how to collect for a perimenopausal woman? So if she still cycles, if she's still in that early to mid perimenopausal part where she may have regular cycles, she may even still be ovulating some months. She's going to still collect 5 to 7 days after ovulation. If she has irregular cycles, then you're the practitioner. What are you hoping to get out of the results? So if she's pretty irregular, like 1 month she got her period on day 21, the next month she got her period at day 45, maybe you're like, look, estrogen and progesterone are in the Wild West right now. Maybe we're just going to do the adrenal only and the other markers we get in blood work, thyroid, cardiometabolic, etc. If she skipped several months of her period, let's say she comes to see you and she said, I haven't had a period in 7 months. You can assume she's in that late perimenopausal. You can assume she's going to be, hopefully, maybe menopausal here soon. She'll hit that 12 months. Now, Murphy's Law says she won't. Murphy's Law says she will get to 11 months, no period, get her period, and you'll have to start the count over again, which is, again, so not fair. I'll change that if I get nominated to be goddess of the female body. But what we do for testing is, look, if it's been several months, just collect any time and lean into she's probably close to menopause. She's in that in-between. She's in that late perimenopause state. And if she's on hormones, Dr. Rice is going to run through some hormones, follow the instructions on the test kit. Now, if she's postmenopausal or surgical menopause and she's not cycling, of course, then you can collect on any day. Just make sure it's a typical day. And again, if she's on hormones, you're going to follow the instructions that are included in the kit, or you can find them on the Dutch test website. So we're going to go through the Dutch test so you can get an idea of, just quickly, just how I look at perimenopause, but then the areas we're going to break down further in the boot camp, because we only have so much time in the live class, and I would love to explore this a whole lot more. And that's why Rupa's given me the opportunity with Dr. Rice to do this boot camp. So page 1, if you are brand new to the Dutch test, this is the summary page. And so the patient's information is at the top. I have it covered for HIPAA purposes. This is an actual case. The ordering provider, the date of birth, and the age, of course. If they have not had a period in a while, on the right-hand side, that last menstrual period area will be blank. Under that will be the collection times. You do want to make sure the collection date and times make sense. You want to make sure they follow the instructions, that they didn't collect randomly over several days, that they didn't collect random times and didn't read the instructions. So as the practitioner, you'll glance at that. Then you'll move down into the gray shaded area and you will see estradiol, progesterone, testosterone across the top. And you will see cortisol on the bottom. But we do go into these in detail through each of the pages. When we get to page 2, this is the line item of all your estrogens, progesterones, and androgens before Dutch puts them in a dial. Where you're going to focus, though, because we're in the perimenopause and even maybe menopause, is what's called this postmenopausal range. So maybe for years you were seeing women, you were focused in fertility, you were focused in PCOS, you were focused in PMS, and now is with the influx, according to ChatGPT, of these over 1 billion women globally entering into menopause, this is going to be your new favorite reference range of where you look. And if she happens to be on oral progesterone, for example, if she's on 100 milligrams of prometrium, then Dutch does change the reference range to indicate that they are on oral progesterone, which Dr. Rice will touch on progesterone. And we have an entire week on hormone therapy in week 6 on the boot camp for that. One of the things I do want to draw your attention to on page 2 for females on the left-hand side, where that pink arrow is, are 3 markers: 5-alpha androstenediol, 5-beta androstenediol, and epitestosterone. These are not put in a dial on page 3, which I will show you in just a second. So you are going to reference back here, especially this is your cheat code, cheat method, when we are looking at the androgens and we are looking to see if she is an alpha person, acne, hair growth in places she doesn't want, history of PCOS, male or female pattern balding. We tend to look only at page 3, but you do want to flip back to page 2 and glance down here, especially if that 5-alpha androstenediol is elevated. Research is indicating it's a better marker for the 5-alpha reductase. DHT likes to stay in the cell. It's an intracrine hormone, converts into 5-alpha androstenediol, and that likes to go out of the cell. While Dutch looks at both, you do want to look at both in your patients and clients because that's not put on a dial. Maybe someday Dutch will put that in a dial for females, but they don't at this moment. Then we're going to go to page 3. So on page 3, you'll see androgens on the left. You will see progesterone in the upper right-hand corner and estrogens and estrogen detoxification in the middle on the right side of the page. So if we cut out just the progesterone portion, here's where things get different. The Dutch test does include the luteal range and the menopausal range in these dials. Because now I understand people get frustrated. Carrie, I don't understand. My patient is menopausal. Why are they including all of the ranges? Why do they have the stars and this little purple box? It's because Dutch doesn't know, as a practitioner, where do you want her to be? Do you want her to be in the area that's known as the gap in between the purple box and the star? Do you want her in the purple box? Do you want her up in the green? That's the luteal range. We actually also, when I was at Dutch, we had a lot of people who were in that in-between perimenopausal state. Sometimes they'd be in the green because they were ovulating. Sometimes they weren't. They were down in the menopausal range. So it's hard for Dutch to guess based on age alone where they are in their menopausal journey. So Dutch said, okay, everybody gets every range. But when we're looking at ranges, the postmenopausal range is the purple rectangular box when you're looking at progesterone. Now, progesterone itself as a hormone is not found in the urine, but you do have 2 metabolites that research says, when a weighted average is done of the 2 of them, indicates how progesterone is doing in the body. For example, this urine marker should be pretty close to if she were to have gotten a blood draw on the same day. The nice thing about the progesterone in the Dutch test is that, again, in the perimenopausal state, she may still be producing progesterone. And because progesterone is pulsed out, it's not continuous, it's pulsed, and Dutch is collected through the day, this progesterone marker is the weighted average through the day, which is different than a blood test, which is just a one-time draw, and hopefully you caught when they pulsed out progesterone. But you have these 2 metabolites, the beta and the alpha, which Dr. Rice is also going to touch on. But the alpha, just as a reminder, is your calming, soothing, relaxing, everything's going to be okay metabolite, because it goes on to make pregnenolone, ALO, not like the plant, but ALO. That goes up to the brain, touches on the GABA receptors, and is very calming. GABA is your inhibitory neurotransmitter. Why is this helpful? Because women say, suddenly, I can't sleep. Suddenly, I'm having anxiety. Suddenly, I don't feel calm anymore. Suddenly, I'm not managing my stress well. One of the contributing factors, it's not the only, but one of them, is that when they lose out on progesterone, they lose out on this alpha metabolite made in their body, and they don't get that extra bonus on their GABA receptors. Now, you will see where the little pink arrow is on the alpha side. People will often ask me, where in the purple rectangular box do I want to be, Carrie? Where am I looking here? And if it's in the purple box, is that good enough? It depends on the person. This person, you can see, at 18 is at the way low end of the range. 15 is the cutoff, and they're at 18. So my guess is that sleep issues, anxiety, stress, not feeling calm is probably a big part of their life. They would do well to have the progesterone be higher. Even though they are menopausal, they'd probably feel better for them to have more progesterone in their body. Now, you're not going to get this from herbs like Vitex. We love Vitex in the cycling woman for the most part. But when she is menopausal, Vitex is not going, that's like squeezing water out of a stone. The lutein cells just aren't happening in the ovaries. In fact, your progesterone production as a female drops down to less than 1 milligram of production. And what happens is it's leaked out of the adrenal glands. So very little progesterone comes around in menopause. Then we have the estrogens. So estrogen, if you've done Dutch tests before, estrogens are on page 3 still, hand side, E1, E2, E3. And so when we look at this, again, we are often asked, where do I want them to be? Where do I want to be in the purple box? Do I want to be in the space? Do I want to be in the green area? Obviously, a lot of that goes to the symptoms they're having. Perhaps this is their level, but they're telling you they're having 6,200 hot flashes a day. Their brain fog is terrible. Their joints ache. Their mood is deplorable. And you're looking at this thinking, God, but you are in the purple box. For them, the personalized individual in front of you, they may need to be higher. They may need to be higher. Now, what's interesting is that a research study was published. This was published, and this is on, you can find this. I have the link here. It's also on the Dutch website under the research area, where they looked at urinary estrogen concentration, so like a Dutch test, and they overlaid transdermal estrogen patches. And if you got on a patch, how much estrogen did it raise up your urinary estrogen? So you can see the very first dot is in that dark gray area. And then if you got on a patch, the 0.25, that bumped you up into the light gray area. And then if you went up in dose on the patch, you moved up into what's called the purple area, the luteal estradiol concentration. If you were to overlay this with the Dutch test, this is essentially the purple box, the gray gap in between, and the green luteal phase when we're looking at this. Now, this is really important to know because when you're trying to adjust not only just the outward symptoms they have, but the inside signs and symptoms that they don't know about yet or haven't been worked up for, or we're trying to reduce the risk of, you may find they do better at the higher end of the dark gray area, the purple box, or even into the gray area, the gap area, depending on high. And then if you have them on a much higher patch, that will put them into the luteal phase. So how much does this equate to? And this is just to give you an example. We'll go much deeper into this in the boot camp. The 0.025 is about 2 milligrams of estradiol, and the 0.05 is about 3.8 milligrams of estradiol. Now, this is important to know because this is the Climera patch as an example. The 0.25, actually, it's the 0.0, sorry, 0.025 and 0.05 at the title. That part's wrong. However, when you use the 0.025 and the 0.05, and they looked at over a week, they did serum concentrations of estrogen. And you can see serum-wise, the lower, the 0.025, got you at about 30, and then you trickle down through the week. And the 0.05 got you at about 50, and a blood draw, and then you trickle down through the week. What's really interesting is according to the North American Menopause Society, most postmenopausal women not on estrogen therapy are under 10. So these patches are pushing you up both in the urine and they're pushing you up both in the blood as well. And the reason I'm pointing this out is because they're actively researching how much estradiol is needed to prevent bone loss and hip fracture. Some research is saying that you need actually to be in the 50 to 70 range in blood, and then the equivalent in urine, if you're trying to reduce the risk, prevent bone loss and hip fracture. How much estradiol is needed to maintain tight junction and intestinal health? Estradiol stimulates the production of tight junctions in the gut. How much estradiol is needed to improve insulin sensitivity and reduce cardiovascular risk? And how much estradiol is needed to help protect the brain? So all these things, all these studies we're going to go into through the boot camp because they're actively being evaluated. And I fully understand not everybody is a candidate for estrogen, nor do some people want any kind of menopausal therapy. So your job as the practitioner is, okay, how are we going to address this in other ways? How am I going to support your gut? How am I going to reduce your cardiometabolic risk? How am I going to continue to keep you away from prediabetes, diabetes, fatty liver, et cetera? How am I going to prevent you from having bone loss? What are we going to do to be proactive? So while using estradiol is definitely an option, or referring out for it, if you're not going to, or if they're refusing it, then you better have a plan on how you're going to be proactive about this. Because as I said, of all the systems in the body, unfortunately, it can be all negatively impacted. And everyone listening today is like the perfect practitioner to come in with a proactive plan and be like, I got this. We can do this. We're going to thrive through menopause. Now, speaking of brain, in 2023, there was a study, and I mentioned a survey by Andrea Donsky and her team at Morphus, and they looked at surveyed 3,000 women. And in fact, Andrea told me yesterday they're up to about 4,000 now. But I love this slide more than anything because these are the top 10 symptoms experienced by women in perimenopause and menopause, according to the 3,000 that were surveyed. So you can see fatigue, lack of energy, brain fog, sleep issues, memory loss, forgetfulness, anxiety, joint pain, lack of concentration, lack of focus, hot flashes, loss, or low libido. Why do I love this slide? Because 9 of them have to do with the brain. 9 of them have to do with the brain. Now they're coming in saying, I'm tired, or my mental ability is not what it used to be. My mood has changed. I'm not the same as I used to be. I can't focus. I'm having these hot flashes. Libido is down. All of these cycle back to the brain. The only one not attached to the brain is joint pain. Joint pain is the only one, but 9 of them have to do with the brain. So when you're working with perimenopause and menopausal women, you better have a plan to how you're going to help protect their brain. And thankfully, this is actively being researched between Dr. Kellyanne Niotis and Lisa Mosconi, and how we can help preserve her brain so that you can reduce or eliminate these symptoms. And then, of course, other risks such as crossed fingers, dementia, and Alzheimer's. So going back to page 3, we will in the boot camp go into estrogen detoxification. Those are the rest of the green, red, and blue arrows as you are on the right-hand side. And then in the lower left-hand side where it says methylation activity. We do treat detoxification a tiny bit different in menopause. We don't so much use products like DIM, diindolylmethane, or indole-3 carbinol. We lean more into other products to work on these SNPs, such as quercetin, resveratrol, sulforaphane, creatine and choline to take the pressure off of methylation. So we'll go into that, creatine and choline. Obviously, methylation support. We work on gut support. As I said, estradiol, when we lose it, our tight junctions become less tight. They become leaky and things slip through. And now we have a big inflammatory event. So with detoxification, we do change it up just a little bit because we don't want to deplete them of any more estrogens. On the left-hand side of page 3, we've got your androgens, DHEA-S, testosterone, and the metabolites, androsterone and etiocalanolone, along with the 5-alpha reductase diol there. Now, what's interesting is that DHEA levels do decline with age. We know that they start to decline somewhere between 20 and 30 years old. And I was reading research yesterday that the average 50-year-old has 70% less DHEA. Of the 50-year-old female is less DHEA than she did at 20 years old. And so while adrenal support is helpful, absolutely, and our ovaries in women, the theca cells do continue to pump out some androgens after menopause. The ovaries aren't completely dead, but they're not exactly efficient and they're not what they used to be, and it doesn't last forever. So the theca cells factories still work a little bit for a couple years through menopause, and then again, the androgens really start to decline. So understanding this about how the androgens work and why she's complaining of some of the symptoms that she has is really important. On page 4, we have the cortisol markers lined out. We also have creatinine at the top, which is a kidney marker. So it gives you an indication of where they overhydrated, if it's too low, so dilute, or if they maybe have a kidney issue, you need to work up. So this is if the creatinine is high. If you see high creatinine levels, make sure you're evaluating kidney because we don't want to miss kidney disease as she's getting older. That puts us into page 5. Now, page 5, definitely important. It doesn't change as much. Melatonin definitely starts to decline pretty significantly once they hit the 50, 55-year-old range, according to Dr. Russ Reiter, who was the big melatonin researcher. That connection between the hypothalamus and the pineal gland, he says, unfortunately, age-related, starts to degrade. And he or she, everybody, stops making as much melatonin as they used to. But the cortisol part, the cortisol patterns still apply. Still, if you took my Cycling 101 boot camp or have worked with Dutch for quite a bit or contacted and called the Dutch resources, that is still about the same with menopause. We just want to make sure they're extra supported because the adrenal glands, like they're one of the glands still like really kicking. And nobody gives the adrenals or the thyroid or anybody the message. Nobody's, hey, lefty and righty ovary aren't working today. And in fact, no more. They're done. So you guys are going to have to pick up the slack. The adrenals and the thyroid and all the other glands don't get that message. Not like we consciously know that it's happening. And so they get extra taxed. It feels like the entire HPA axis with that loss of estradiol and progesterone, supporting her in an HPA-related fashion will only help everything in the whole body extra as she goes through menopause. And lastly, we have the organic acid page before I turn it over to Dr. Rice to talk about the hormone part of it. But when we look at these, you definitely, as she is heading into menopause or menopausal, we evaluate this the same as if it were any age. We're looking at that B12 marker. Remember that B12 marker is not methylcobalamin, despite the name methylmalonate, even though it says methyl in it. It's actually adenosylcobalamin. It's the B12 that starts with an A, adenosylcobalamin, and that's what supports the Krebs cycle. And we want to make sure because when women head into menopause, their fatty acid breakdown and then into beta oxidation, unfortunately, slows way down. And everything beyond that, the Krebs cycle, the electron transport chain, isn't as efficient as it used to be. And so she feels it. Not only is she gaining visceral adipose tissue around her center, her middle, she's got energy issues in her muscles, in her brain, just how she feels, and things like B12 that can help support that. We have the B6 marker, the glutathione marker, biotin marker, gut marker. Again, remember I said the decline in estradiol negatively impacts things such as the tight junctions. It also negatively impacts the mucus layer in the GI tract, and we need that mucus layer to act like snot and trap things so that your immune system can get to it. You've got your dopamine, norepinephrine metabolites. Do keep in mind these are metabolites. These are not a one-to-one for dopamine, norepinephrine, and epinephrine, but they can be really quite helpful and correlate with symptoms. And then we have the big marker it's the first marker it's the marker I am the most concerned with on this test. That's the quinolinate, which is a brain on fire marker. And if I see an elevated quinolinate, she's heading into perimenopause and menopause. I'm really concerned because remember, 9 out of 10 of those symptoms in the top 10 symptoms were brain related. Quinolinate or quinolinic acid, depending on what literature you're reading, indicates that we have brain on fire, that we have microglial activation, and we don't want that. Melatonin we mentioned, and then we have the second marker that I really don't like to see elevated, and that's 8-OHDG. I don't want to see that DNA damage. If this is elevated, in this case, you can see this is a menopausal woman. Her 8-OHDG is 5.9. We've got to figure out what's going on, and we have to get that DNA damage reversed, repaired ASAP. We want to reduce that risk for anything naughty moving forward. So what I will do is I will stop share, let Dr. Rice take over with her slides, but just as a super selfish plug she and I are doing the perimenopause and menopause 101 starting March 18th. So make sure you register because we're going to go into everything I talked about and she talks about over the course of 6 weeks. So Dr. Rice, I will stop sharing so that you can start sharing.
Thank you so much, Dr. Jones. All right. Let me get on the right slide here and get us started at the top. I'm going to put us in presentation mode. And here we go. So for today, and this is something to tag on to, right? Like when we think about what happens in menopause, like the ovaries really are the main determiner of how we're going to live the rest of our lives. Like I would agree. I'd like to request an assistant goddess position in helping to support education and redesign on that. What we're going to do now is walk through the Dutch test and menopausal hormone therapy. So this is what hormone replacement therapy is going to look like on the Dutch test. That's what we're going to cover. And for today, we're only going to cover progesterone and estrogen. There is also DHEA, there's testosterone, there's all sorts of other hormones that we can consider. But for today, as a teaser, we're going to look at progesterone and estrogen on the Dutch test. So Dr. Jones walks through how to read the test, what those specifics on the luteal range between the stars here are for, and then that postmenopausal range. And when we're looking at menopausal ranges, so we can do baseline, right? If we're doing a baseline test for somebody that is menopausal, we're likely going to find that person in that postmenopausal range or lower, sometimes a little bit higher. But the supplemental levels are probably going to be it can just kind of be like throw it against the wall and see what happens. But generally, we're going to see that in that postmenopausal range or a little bit above that star when we're talking about estrogen. And progesterone will also look a little bit different here. So this guide, the monitoring matrix is really helpful when you're trying to understand like, oh my gosh, my patient's on testosterone and estrogen and progesterone. And should I do a Dutch test? Should I do a serum test? What kind of testing should I do to get the best information? This, I think, is a very helpful and objective view on, okay, I have somebody that's on oral progesterone. What am I going to get? I have somebody that's on an estradiol gel or a biased gel. What is that going to get me? So this matrix can be really helpful to help walk you through where the data can be most helpful when you're trying to support your patients. So for this one, this slide is really looking at progesterone and where progesterone can be useful, like when we're testing for progesterone. So this is oral progesterone, OMP, which is oral micronized progesterone. We find that dried urine testing is helpful not to monitor the amount of progesterone that this person is taking, rather to look at that breakdown of those alpha and beta metabolites that Dr. Jones was talking about. And this is so we can get a better understanding of how the body's breaking down that progesterone so we can support that patient better, right? Are they having issues with sleep? Are they having issues with anxiety? Let's look at what's happening with their alpha and beta balance. So that's where the Dutch test can be really helpful with oral progesterone. We also see the other blue here is vaginal progesterone. So we don't recommend doing Dutch testing with vaginal progesterone. And it's usually due to the fact that when you're using vaginal creams, it can influence or muck up what those results look like. So it's not a true representation of that progesterone application for the patient. We also see for oral progesterone in serum, not a great option just because so if we are to do progesterone as a cycling female, no things are going on. What we find in research is progesterone does this all day long. So it's really difficult to get a baseline of progesterone, even when you're not supplementing. Now, we add oral supplementation to that. And because when you take something orally, it has to go through the liver and the liver dumps a bunch of metabolites, that can also really make some crazy readings when we look at blood testing for progesterone. And this is not super helpful, but helpful. Big question mark on whether blood testing with vaginal progesterone could be helpful, right? Like we can see increases that happen, but we don't really know how that is happening with the uterus. And so we don't really know that target tissue effect with vaginal progesterone. So, really, when we're looking at progesterone, what we're wanting to do with the Dutch test is evaluate those metabolites and how we can support our patient with the alpha and the beta metabolism. So progesterone, this is what that progesterone looks like that you saw on page 3 of the Dutch test. So it'll be page 2 of sex hormones only, page 3 of a Dutch complete or a Dutch plus. And really the key points on this are to evaluate that alpha versus beta metabolism. So the beta metabolites are the most abundant in the body, which is why they are important to look at. Like it gives us a really nice approximation of what that progesterone can be. But the alpha metabolite comes in and can be helpful in because the alpha metabolite does that allo conversion, ALLO, as Dr. Jones was saying, not aloe the plant, crosses the blood brain barrier, stimulates the GABA response in the brain. And so when we think of that GABA response and the alpha metabolite of progesterone, we want to think calm, sleep, less anxiety. Like I look at progesterone as the soothing mama hormone. Like she comes in and calms everything down. The alpha metabolite is really what like drives that home. That's really the key hitter for our oral progesterone. The most common uses of progesterone are oral, transdermal, which is a cream, and vaginal progesterone. And I would say in general, and looking at thousands and thousands of Dutch tests that come through and looking at the guidelines, I would say the most common use that we see is oral progesterone. We do also see a lot of transdermal progesterone. These are the ones that you can get over the counter. And that's why it is also something that comes up a lot. Vaginal progesterone, I think, is reaching some popularity, but it's still not as common as it used to be. When we're looking at progesterone metabolism, we're really looking at that comparison for relative preference of metabolites. And that is, do we favor the alpha? Do we favor the beta? The low alpha metabolites may include poor sleep, increased anxiety, decrease. This can happen even just with a drop in progesterone. So raising that progesterone in general is going to be important to help improve some of those things. But it's that alpha metabolism pattern that we can see on the Dutch test that can be helpful. And if we go back to our person here, wait for it, we can see that this person, now we want to look at the noses of these dial gauges relative to each other. So we have that beta pregnane dial that's pretty robust. We have the alpha pregnane dial that's a little bit less than midway. When we're looking at that relative relationship, we can see this person metabolizes more down the beta pathway than the alpha pathway. So this person may not be getting that same boost and the alpha metabolite if she's taking 50 milligrams of oral progesterone. She may need a little bit of a higher dose of oral progesterone to really push that alpha preference or that alpha outcome that we're wanting with oral progesterone. The other thing to look at here is when we do oral progesterone, as Dr. Jones had circled in the results, we adjust for oral progesterone ranges. Here, this is where when we're adjusting for those oral progesterone ranges, this ends up putting the progesterone values for the beta and the alpha within that luteal range. So it's between those stars. This is not uncommon to see with oral progesterone. And so this is an example of somebody who is on 120 milligrams of oral progesterone. So the Dutch test is relative to 100 milligrams of oral progesterone. And this is where we can see how is this person metabolizing their progesterone. And the ranges are adjusted here to account for that metabolism in the liver, right? Because we know all of a sudden you're going to get this big, like fire hose of progesterone that's metabolized through the liver. And we want to be able to see what that looks like. Our next up is estrogen. So, this is, I would say, the most common supplemented hormone therapy in peri and postmenopause. And this one is highlighted in purple. So, we can see we have estradiol patches, estradiol gels, and creams. And when we're looking at this, dried urine is actually a really great way to measure estradiol as a patch. We can see that there are actually good studies that show if we do a topical estrogen in serum and we compare it to topical estrogen in Dutch, they have good correlation. So whether you're doing serum or Dutch, you're going to have pretty consistent information that you can get. The difference is we can also see how well the body is metabolizing those. You can get a really good representation of your estradiol topically in dried urine, whether that's patches or creams. In serum, you can get a really great representation. The only other impact on that is how well the tissue effect is. And that is something to consider with estrogen metabolism. And that's something that we can also see with estrogen or with Dutch testing and estrogen. So on the Dutch test, it is useful for estrogen levels in general. So you're looking at your E1, E2, and E3. Those more specific ones are going to be that E2 estradiol and E3 estriol. And we want to look at that estrogen metabolism. So Dr. Jones touched on that with our phase one, which is the 2-OH, the 4-OH, and the 16-OH. That's our hydroxylation, where we make it messy before we clean it up and send it out to be released from the body. And then we have phase two, which is that methylation. So the most common types of estrogen supplementation are topical, oral, and vaginal. And when we're looking at topical supplementation for estradiol, we have the patch, we have some creams, we have some gels, and then again, that oral and vaginal. Here, I wanted to break down a little bit more on what we see. And this is both topical, well, all three, topical, oral, and vaginal, but we can get estradiol all by itself. We can get estriol all by itself, or we can get a combination, which is called bi-est. That is usually estradiol. It is estradiol and estriol. I wanted to put a little example in here so you could see the combination is based on percentages of how much of an E2 presence there is versus an E3 presence there is. And these are the general, more common doses that we see with a bi-est, an 80-20, which is 80% estriol, 20% estradiol, or a 60-40. Usually the lower percentage is your estradiol because the estradiol is the more potent form of supplementation. And you can also see a 50-50. So 50% estriol, 50% estradiol, and we can see what that equivalates to here. So when we look at the most common types of estrogen supplementation, we generally recommend and say that topical estradiol or estrogen supplementation is the safest. Oral supplementation is actually used a lot, and we do have a little cautionary tale with that. If there are cardiovascular or clotting concerns, we want to be aware of that because oral estrogen supplementation can negatively affect that. We do also have vaginal, which is safe, but we want to consider how close that is to the uterus. So overall, the topical estrogen is generally considered the safest. So this is just a peek into what estrogen can look like on the Dutch test. So on the left-hand side, we have a topical estradiol patch. So Dr. Jones went through what the different patches could look like and how you could see those changes show up on the Dutch test. This is someone who is on a 0.0375 patch. This is what her estradiol is going to look like. And because the estradiol patch is estradiol, we want to look at that estradiol, see what that effect is. And that's pretty awesome. We can see the 0.0375 and her estradiol level is 0.36. Now, the reason why I put the rest of the estrogens here, that E1, E2, E3, is so we can see E1 and E2 convert back and forth into each other, right? But once E2 goes to E3, there's no going back. So when we have estradiol that's being given to the body, we also may need to consider what that effect looks like for her E3. And we can see with this estradiol patch, she's not having any other supplementation of an E3 or a bias or anything like that. She is converting a bit to the estriol as well. This is a topical biased cream. So this is an 80-20, which means she has 80% of the estriol and 20% of the estradiol. And we can see her estradiol is still in that postmenopausal range. Her estriol is in that postmenopausal range, but on the higher end. But that is that combination of both the E2 and the E3 as a cream. And then just below that, we have estriol cream all by herself. And we can see when we're supplemented with estriol, that can do a pretty significant boost to our estriol here. And just in comparison, and looking at her E1, E2, and then E3, right? Like her E2 or poor E2 is even below that postmenopausal range. Her E3 is like going to town, and that is due to that supplementation. One of the things that I did want to put on here is absorption may be variable from person to person. So in the research, we can see depending on the person's metabolism, depending on how well they can absorb certain creams and patches, we can also see some variances in what that estrogen or how that estrogen can show up on the Dutch test. So this was just a little bit of a comparison here. So we have that same estradiol patch, the 0.0375, as we saw before, but here is a topical estradiol patch at 0.025. So this person who is only doing the estradiol patch and progesterone, her supplementation puts her above that postmenopausal range. Now look at the difference here. Now this could be a difference between how they absorb, how they are metabolizing, when they put their patches on, right? Like you're doing your patches twice a week. Had she just put this on? The other person, is this on their like last day of estrogen? So these are the types of considerations you also want to make when you're evaluating what the estrogen doses look like on a Dutch. I also wanted to add in that E1, E2, and E3 so we can see how her body is metabolizing from that E2. But this person at a 0.025 shows a higher estradiol than this person at a 0.0375. So not all supplementation is created equal, because why? We are all individuals, right? So we want to take that into consideration when we're looking at treatment and evaluating dosing on any kind of testing, but Dutch test too. The other things that I included here was because, yes, we want to get that information on that estradiol, but we also want to see how that estrogen metabolism may be affecting what's going on here. So this woman who was doing the 0.0375 patch, we see that E1, E2, E3. We also have her phase 1 estrogen metabolism and her phase 2 estrogen metabolism. We can see on her phase 1 pie chart here, she's got a lot of blue, a little bit of red, and then some of that green. Now, this is flipped from what we would like to see, right? Like we want to see the majority being green, still a little bit of red, and then a little bit, like a quarter part of that being blue. So we can see she's got some issues being able to clear that estrogen through her phase 1 metabolites. And we can also see when we look at her methylation, she's leaning towards the low end there. So she doesn't have optimal methylation. What this tells us is she's getting that estrogen supplementation, but we also want to support her in that estrogen metabolism, right? The person on the estradiol 0.025 patch, so her phase 1 metabolism was good, but her phase 2 metabolism, check this out, her methylation gauge is all the way over in the low end range. So when we look at that, this is really, right, like Dr. Jones talks about the bathtub theory, and really it's the ability to fit everything out through that filter, right? And if your filter is really tiny and you can't squeeze it through, you're going to get those estrogens clogging up the drain. And that's where you can see some of these higher estrogens, right? So for this woman, is it because she can't clear her estrogens very well and they keep getting recirculated, right? So that is where the part of estrogen metabolism can come in really handy to give you as a provider perspective on, given what I'm giving her, even though this is the lowest patch dose, she's still got a higher level of estrogen, and we want to support how her body can metabolize that. So the take home, like the takeaway messages here, are progesterone is most commonly dosed as oral, and progesterone should not be tested to monitor levels, Rather, it can offer information for metabolite preference, which can influence that sleep and mood. So, again, that alpha and beta balance with our progesterone. And oral progesterone is best for endometrial protection, as outlined in research. So, we're not looking at this to determine, okay, is she getting the progesterone to protect her endometrium? We are looking at really supporting the lifestyle factors there, not endometrial protection. Endometrial protection through oral progesterone is research supported as 100 to 200 milligrams. Key takeaways for estrogen are that Dutch correlates well with other testing, serum, and can monitor estrogen. Dutch also shows metabolism to understand the pharmacokinetics, so how that person's body is utilizing that estrogen, as well as metabolism.
Hi, everyone. We hope you enjoyed this class. If you're a practitioner, make sure you go sign up at rupahealth.com. And if you like this video, don't forget to like and subscribe.